Buenos días con todos. Por favor, si me permiten compartir pantalla. Bien, mi nombre es Jaime Moyano. Les saludo desde Quito, Ecuador. Soy vicepresidente de SILACO. El webinar que vamos a tratar el día de hoy se denomina Cirugía Mínima Invasiva en la Escoliosis del Adulto. Esta es una patología cada vez más frecuente a consecuencia del aumento en la expectativa de vida. Tenemos como conferencista invitado al doctor Richard Fessler, quien es profesor del Departamento de Neurocirugía de Rush University Medical Center de Chicago, Illinois. Fue también profesor y vicepresidente de neurocirugía en la Escuela de Medicina Feinberg de la Universidad de Northwestern, profesor y jefe de neurocirugía de la Universidad de Chicago, y también fue director de educación y servicios clínicos en el Brain Institute de la Universidad de Florida. Doctor Fessler, le agradecemos muchísimo su presencia el día de hoy. Nos sentimos muy honrados con su participación.
Good afternoon, everyone. Thank you. I'm pleased to be here.
Bien, tenemos para la presentación del caso clínico al doctor Sergio Soriano, de México. El doctor Soriano es cirujano ortopédico de columna vertebral, especialista en cirugía mínima invasiva, es médico de la clínica de columna del Centro Médico ABC, miembro activo de la Asociación Mexicana de Cirujanos de Columna y del Colegio Mexicano de Ortopedia. Tenemos un grupo de selectos panelistas, entre ellos el doctor Jorge Ramírez, de Bogotá, Colombia, miembro de la Junta Directiva SILACO, paz presidente SILACO, paz presidente de la Sociedad Latinoamericana de Ortopedia y Traumatología, de la Sociedad Internacional de Cirugía Mínima Invasiva, de la Sociedad Colombiana de Ortopedia y Traumatología. El doctor Ramírez es un pionero en cirugía mínima invasiva de la columna vertebral y autor de libros de la especialidad e innumerables artículos indexados. El doctor Julio Urrutia, de Chile, presidente electo de la Sociedad Chilena de Ortopedia y Traumatología, past presidente del Comité Chileno de Columna, profesor titular del Departamento de Ortopedia y Traumatología de la Pontificia Universidad Católica de Chile y miembro de diferentes sociedades científicas de la especialidad y revistas. El doctor Máximo Alberto Díez Ulloa, de Santiago de Compostela, España, es expresidente del Grupo Español para Estudio del Raquis, miembro del Comité Científico SILACO, profesor asociado de la Universidad Santiago de Compostela y Educational Advisor de AO Spain. El doctor Alejandro Morales Ciancio, de Mendoza, Argentina, es jefe de la unidad de columna del Hospital Español de Mendoza, miembro titular de la Sociedad Argentina de Patología de Columna Vertebral, miembro activo de la Sociedad Internacional Mínima Invasiva, de SOLAS y de la North American Spine Society. Como coordinador, el doctor José Antonio Soriano, de la Ciudad de México, es segundo vicepresidente SILACO, presidente de la Sociedad Mexicana de Neurocirugía, presidente electo de la Federación Latinoamericana de Neurocirugía y paz presidente de la Asociación Mexicana de Cirugía de Columna. El programa se iniciará con la charla del doctor Richard Fessler, Minimally Invasive Surgery for Adult Scoliosis, Who, When, and Why. Tendremos luego preguntas y comentarios de nuestros panelistas, presentación del caso clínico a cargo del doctor Soriano, discusión del mismo por parte de los panelistas, resolución del caso clínico y preguntas de la audiencia. Finalmente, el doctor Hani Mahidli, presidente de SILACO, dará unas palabras de cierre de este evento. Doy entonces la palabra al doctor Richard Fessler para su conferencia. Por favor, doctor Fessler.
Thank you, everyone. Good afternoon. It's a pleasure to be here with you. And I believe my screen is being shared, so everyone should be able to see the visual portion of this talk.
Not yet.
No, not yet? Okay, then let me go back and go here and share the screen.
No, todavía no, Rick.
Coming right now.
Yes.
Okay.
Ahora sí. Thank you.
Very good. These are my disclosures. And some of them are relevant to this talk in that I do consult with DePuy on development of their scoliosis system. And I do get some royalties from that. So this talk is going to be based partly on my research at the various universities I have been at, and partly on the basis of a research group that I am part of called the International Spine Study Group. And these are just a few of the 40 or 50 publications that we have generated so far from within this group, all of which deal with minimally invasive scoliosis correction in adults. So we know that there are many advantages to minimally invasive surgery in general. We know that there is less blood loss, that there is a lower infection rate, there is a less physiologic stress response in the patient. It usually results in minimal or no intensive care unit stay and a shorter hospitalization. The patients typically require less medication and have a faster recovery. And the major reason for all of these things is because there is less soft tissue destruction when we do minimally invasive surgery. Specifically in relation to deformity surgery, there are several other possible advantages. For example, can we decrease the number of levels fused and instrumented if we use minimally invasive technique and therefore do not strip the spine of its paramusculature innervation and its nerves and blood supply? For the same reason, can we lower the incidence of proximal junction failure and distal junction failure? And can we decrease the overall cost of the surgery by doing minimally invasive technique? And there are several other questions we can ask too. Will minimally invasive technique in scoliosis increase or decrease the rate of complications in deformity surgery? It's been argued that using minimally invasive technique, we really can't do a very good job of correcting sagittal deformity. And if we use minimally invasive technique, can we do complex cases? Or are we really limited to just the easy cases of scoliosis? So we're going to address all of these in this talk. So here, for example, is a case. This was a retired nurse from one of our institutions who came in with this nearly 50-degree curve in her lumbar spine, which was partially compensated in her thoracic spine of 13 degrees and at her lumbosacral junction with 21-degree curvature, so that you can see that her sagittal balance actually is pretty good. And you can see that her scoliotic curves bend out pretty well, so they're not rigid. So how can we approach this patient's scoliosis? If we're going to do minimally invasive technique for scoliosis, we need to be able to do all the techniques that we would otherwise do using open surgery. So in her case, we're going to do a lateral lumbar interbody fusion at the appropriate levels between L4-5 and between T12-L1. And at L4-5 or at L5-S1, we can do an A-lift or a T-lift when it's appropriate. We can use hyperlordotic cages to help us with sagittal balance. And we can do it staged so that we do the anterior parts on one day and the posterior instrumentation on a second day. We do this through a posterior midline incision. And the only thing that's incised is actually the skin. The muscles are never cut, they are merely dilated through. We can do percutaneous pedicle subtraction osteotomies. Now, we found that with minimally invasive technique, this is rarely necessary. We can do Smith-Peterson osteotomies, and we can do facet fusions in the thoracic spine. Then we can follow up with percutaneous pedicle screws and a percutaneous subfascial passage of the rod. So to do the lateral lumbar interbody fusions, we start out in a direct lateral position with the patient being supported on a bean bag and an arm support of the elevated arm so that the weight of her arm and shoulder does not twist her spine toward the ventral side of her body. We tape the skin, not a towel, but we tape the skin so that for patients who have a significant rotary component, we can then turn the table so that we are always working perfectly perpendicular to the floor, and the tape will keep them from falling off the table. We position over the crack of the table and bend the crack somewhat to increase the space between the bottom of the rib cage and the top of the pelvis. And if necessary, as I said, we bend the table front or back in order to get a perfectly perpendicular approach to each of the individual vertebral segments. So for example, at this point, we've got the patient in a lateral position. We have marked where we want to make our incision so that it is immediately over the midpoint, or perhaps even slightly ahead of that, about the 1/3 line of the vertebral bodies. We make our incision over that, and then we approach the discs, and there are a number of ways this can be done. I personally prefer to stimulate my way through the iliopsoas muscle so that I know I'm not going to injure the femoral nerve, which is the nerve at greatest risk. So we make an incision in the skin. I bluntly dissect through all of the soft tissues until I see the fascia of the external oblique muscle. I incise this under direct vision so I do not injure the iliohypogastric nerve, which will give the patient a flaccid abdomen and can give them burning dysesthesia in their penis, scrotum, and vaginal area. So I do it all under direct vision, never using Bovie, and never really cutting. The only thing I cut is the fascia, and then I bluntly dissect through the external oblique, the internal oblique, and the transversalis. One very important part of this technique is to, under direct vision, sweep the peritoneum anteriorly and visualize the entire lateral aspect of the iliopsoas muscle so that you don't get a loop of bowel stuck to the iliac muscle, the iliopsoas muscle, and injure it in your approach. Once that is all done, then I put a K-wire into the appropriate part of the disc space through my Jamshidi needle and dilate over that so that I expose our disc space. There are many different dilators that you can use. I'm showing three different ones here. They all work about the same, and they're all fine. Again, here's a different one still, and it's showing that we're in place right over the vertebral body. Here you can see the disc space. You can see the artery going right alongside it, the radicular artery from the aorta. And after cleaning out the disc space, we then put it in our cage. And your cage can be anything from normal lordosis, which is 6 degrees, to hyperlordosis, which goes all the way up to 30 degrees. And it depends upon what you're going to need to return that patient to a good sagittal balance. Once those cages are in place, and in this case, you can see we put in 4 cages for this patient. And this is the patient I just showed you before. And we did that through 2 separate incisions. I typically can get 3 disc space levels through a single incision, but if I have to do 4, I generally have to do a second incision for the 4th level. Then we turn the patient back into a prone position, incise the skin, the entire length of our working area, and I make 1 long midline incision because cosmetically that turns out to be much nicer than multiple independent stab wounds going up and down the spine bilaterally. But again, the only thing we cut is the skin, and from then on, everything we do is dilating through the fascia and the muscle. This shows doing an L5S1 TLIF. I found through experience that on the bottom of a long construct, a unilateral T-lift cage is not large enough to guarantee a fusion and support the very long moment arm that's created by scoliosis correction above that. So now, rather than doing T-lifts now, I almost always will do an A-lift, and then I'll do it at 5.1 and 4.5 most of the time. Once all of your levels are fused, you've done your interbodies, for which whatever technique you're going to use, and you've done facet fusions above that in the thoracic spine, then you can do your percutaneous instrumentation. I personally use fluoroscopy and the bullseye technique in order to place my Jamshedes and K-wires, but I know many other people like to do image guidance using the O-arm or some other form of image guidance, and I have no problem with that either. Then, after all my K-wires are placed, as you can see right here, we begin our process of dilating and placing our screws over them. These are two different systems I'm showing you. This is the Medtronic system. This is the DePuy system. I actually prefer the DePuy system now. It's not quite as bulky. It's a little bit easier to work with. So in this lady that I showed you earlier with this large coronal deformity, she ended up looking like this. Again, she still has excellent balance, but her coronal deformity is completely corrected. This lady had had a previous kidney resection, and we actually were able to go through this, safely go through the same pathway. So previous abdominal surgery is not a contraindication to a lateral approach. So what kind of results can we expect with this? What we found, so this is a minimally invasive procedure. This is an open procedure, and this is a hybrid procedure. And by that, I mean the A-lifts, T-lifts, and lateral lumbar interbody fusions were all done through minimally invasive technique, but the posterior instrumentation was actually done using a standard open technique. So this was their preoperative Cobb angles, pretty close, not quite as much in our minimally invasive group. Postoperatively, our Cobb angles were all excellently corrected. And in fact, our minimally invasive group was even a little bit better than the others. And the change in degrees in terms of our correction of the Cobb angle, so the lateral scoliosis, was essentially the same in all of the groups. In terms of our lordosis, preoperatively, they were about the same. Postoperatively, they were improved a little bit, and it turned out that the oblique, hybrid technique actually did our best corrections of lordosis. In terms of the pelvic incidence minus lumbar lordosis values, interestingly enough, again, hybrid did the best. The open technique did better correction than the minimally invasive technique. So we didn't get as good of corrections. And I'll tell you that this was our research early on, and I'm going to show you the differences in the way we're doing it now later on. In terms of the SVA, we had very minimal improvement using minimally invasive technique, as you can see, but our SVA was normal to begin with. So there was really no attempt to change the SVA because it was already normal. Now, what about our clinical results, though? So even though we didn't correct sagittal balance as well using minimally invasive technique, our visual analog score for back pain, for leg pain, and our ODI scores were at least as good using minimally invasive technique or better than either hybrid or open. So this suggested that absolute correction of sagittal balance in an elderly population might not be as important as many people were arguing that it was. And what we found looking at this in more detail was that in a young person, correction of sagittal deformity was very important. Postoperative ODI was very different in the young population versus the old population. So if you're young, it's very important to correct sagittal balance. But in an older person, we found it didn't make any difference. Their clinical results were good, whether they got perfect correction or not. So a young person, correction of scoliosis is different than correction of scoliosis in an older person. In terms of blood loss, our blood loss was about 1/4 that of open surgery, highly significantly different. And the frequency that we had to transfuse a patient dropped from over 80% to approximately 30%. It is really quite rare for us now to do a transfusion in a scoliosis patient using minimally invasive technique, regardless of how many levels we're operating on. Operative time is about the same for open and minimally invasive surgery. The hybrid technique, interesting, took a lot longer. So why is that? Because in open technique, you're doing a big dissection, and then you're doing totally posterior, almost nothing anterior. Much of the time in minimally invasive surgery is done anterior with there's minimal posterior time because we don't do a muscle dissection. In hybrid technique, however, they took up a lot of time in the anterior, but then they also took up a lot of time in the posterior muscle dissection. So it took them a lot longer to do their surgery than it did either open or minimally invasive. Now, question we had in the beginning was, will minimally invasive surgery allow for shorter constructs? Well, in looking at that, we looked at minimally invasive and we looked at open. We looked at blood loss, the number of levels done, and their clinical outcomes. As I just showed you, the clinical outcomes were pretty much exactly the same for visual analog and ODI between open and minimally invasive groups, but the minimally invasive groups had far fewer levels fused than the open groups. So this suggested that we can get equal clinical results, but fuse fewer levels in, for example, 10 open and 5 for minimally invasive, but equal clinical results. So the answer was yes, we can fuse fewer levels. And why is that? That is because we are not dissecting the muscular attachments to the adjacent level vertebral bodies. So if we're dissecting all the muscle off the spine, then we have to protect the spine, which means we have to go well up into normal areas in order to make sure that we really get a good correction of the scoliosis and minimize adjacent segment failure. Since we are not doing the muscle dissection in minimally invasive technique, we don't have to do that. Okay. What about reducing the incidence of proximal junction kyphosis? Well, when we looked at it, let me go back to that. When we looked at it, we did not see a significant difference in proximal junction kyphosis or reoperations between minimally invasive technique and open technique. Now that's for proximal. When we looked at distal, we found that when we stopped short of the sacrum, our reoperative rate was actually less in minimally invasive surgery than in open surgery. So in this group, we're going all the way down to the S1. In this group, we're stopping at L5. This group also had iliac wings. And although we had a small group of patients, we did not quite reach significance. The difference was actually quite striking. Only half the reoperative rate when we were stopping short of the sacrum than when we went to it. And in terms of operative cost, we looked at our cost at Northwestern, and we looked at it in great granularity. How many blood products did they get? What cardiac ancillary services did they require? What was their requirements for ICU nursing? How much imaging did they get? How many laboratories did they have to have drawn? How long were we in the OR? What were the pharmacy costs, et cetera, et cetera. And in the end, not including rehabilitation, we found that minimally invasive surgery saved $122,000 compared to open surgery. So early on, we said that we knew we would have less blood loss, a lower infection rate, less stress response, shorter ICU stay and shorter hospitalization, less pain medicine, faster recovery, and decreased soft tissue destruction. And now we have also seen that, in fact, we can decrease the number of levels fused and instrumented. We can decrease cost, and we don't know the answer yet to proximal or distal junction kyphosis, in that the results differed between proximal and distal. So what about our questions? Will minimally invasive surgery decrease or increase complications in deformity surgery? Can we correct sagittal deformity? And can we do complex cases, or are we limited to very simple cases? Well, here's our complication rate. So here's our complication rate in open surgery. Major complications are 45%. Hybrid, they were 33%. Minimally invasive, they were 10%. So a great decrease in major complications using minimally invasive technique. What about a patient profile? Who is a candidate for minimally invasive correction of scoliosis and who is not? Our early results suggested that, again, it was only the more simple cases that we could really do well with minimally invasive surgery. And that when it got to be more complicated, minimally invasive surgery did not correct their scoliosis as well. So SVA under 6 centimeters, a PI-LL mismatch under 30 degrees, pelvic tilt under 25 degrees. And that matched the algorithm that we then created to help people decide what technique they should use when they're doing deformity correction. If, for example, they were not fused, did not have a rigid spine, had an SVA less than 6, a pelvic tilt less than 25 degrees, a mismatch less than 10, and a coronal cob less than 20, they probably didn't even need fusion. You could just do a decompression. If any of those failed, however, and you went over here and you had a mismatch, less than 30, but greater than 10, thoracic kyphosis less than 60 degrees, thoracolumbar less than 10, then you could do a minimally invasive technique with them. If they didn't have some of those things, they became a more complicated. What it turned out was that if you were an experienced minimally invasive surgeon doing scoliosis, you could probably get away doing a much more aggressive operation in some of those patients who had much greater deformity. And if you didn't have that, until you did, it was better to stick with the easier cases. The cases that do require open surgery are the cases that are already fused over 5 levels from previous surgeries, where you have to go in and you actually have to take down their fusions and refuse them, recorrect their scoliosis. Now, could this be done minimally invasively by a very experienced surgeon? Yes. Is it worth it? Probably not. Now, how about correcting sagittal deformity? The arguments have been made that you really can't do a good job on sagittal deformity. And in the early days of our learning curve, that was pretty true. But we were missing a couple things. We did not have hyperlordotic cages at that time. That has made a tremendous impact. And I developed a technique a number of years ago now called the push-through technique. So the problem in passing a rod in scoliosis, when you've got all of your towers in place, is that you've only got about a 6 centimeter space in your towers to pass your rod through. So if you have to do a very large lordotic bend, you can't pass your rod through your towers. So we developed a technique where we only did a gentle bend, making it easy for us to pass the rod, but then we would start on the cephalad end and pass it all the way through the caudal end, but then we would push it out of the patient and then do our hyperlordotic bend after that and pull it back. In that case, you didn't have to try and pass it through, you already were through, and all it did was give you a wonderful lordotic bend with a very easy rod passage before that. So here, for example, you can see this patient has a very flat back. She is 14 centimeters off sagittal balance, and even with a very short construct, we reduced her to essentially a normal sagittal balance, and she had a good coronal correction as well. Preoperatively, she could walk no more than 50 feet. Postoperatively, she was unlimited. How about rigid thoracic scoliosis? This is another case where it's argued that minimally invasive surgery can't do it. However, if you look at this patient, very large, rigid thoracic scoliosis, balance is pretty good, and we gave him an excellent correction and maintained his balance very nicely, all through minimally invasive technique, only using facetectomy and facet fusions in all of those different levels. This is another patient, 18-year-old basketball player who had a rigid thoracic scoliosis, got an excellent correction, excellent balance, and he is still playing college basketball. How about rigid double major curves? Now, everybody thinks that these are going to be really hard because with the double major curve, how do you pass your rods? So here, for example, is a young female who's got a 59-degree curve at a thoracolumbar junction, compensated by a rigid 56-degree curve in her thoracic spine. And you can see how rigid she is. Neither one of those bend out whatsoever. Minimally invasive technique, totally using a completely posterior approach with facetectomies and facet fusions. She was reduced to a 24-degree curve and perfect sagittal and coronal balance. Lumbar spine, again, was 0. This is another 48-year-old male. He does have a huge curve in his thoracic spine here as well. And again, we gave him excellent correction and maintained excellent sagittal balance using complete minimally invasive technique. This is a man who teaches people how to drive buses in the city of Chicago, and he is back at work. Now, what about a rigid thoracolumbar kyphosis? Not scoliosis, but kyphosis. So if you look at this gentleman, his scoliosis in the coronal angle isn't too bad, but he's got a rigid 35-degree curve at his thoracolumbar junction, which is putting him 9 centimeters off balance. Totally minimally invasive technique. Did not do a vertebrectomy on this person or a pedicle subtraction osteotomy. Hyperlordotic cages down below, hyperlordotic cages going laterally up here, and then pedicle Smith-Peterson osteotomies in here, and we were able to get him down to a perfect sagittal balance of, I believe it says, almost less than 5 centimeters, and excellent coronal balance as well. So in answer to our questions, can we decrease complications in deformity surgery using minimally invasive technique? Yes, we decrease it dramatically. Can we correct sagittal deformity with the newer techniques we're using? Absolutely, we can correct it just as well as with open surgery. And can we do complex cases with minimally invasive surgery? Well, we've seen rigid thoracic scoliosis corrected. We've seen very large dual curves corrected, and we've seen extreme kyphotic angulation corrected minimally invasive. So the answer to all of those is yes. So to summarize, correction of spinal deformity using minimally invasive technique is a reality now for most types of scoliosis. It depends upon the experience of the surgeon. Our technology and our experience are still early in development. I think it's going to get easier and and we'll be able to do more complicated cases as we get more and more experience and better instrumentation. The anticipated benefits are already clearly proven using minimally invasive techniques, and although the results are still very early, they are very encouraging for the future application of minimally invasive technique to scoliosis. Thank you.
Muchas gracias, Dr. Fessler. Magnífica su presentación. Nos ha mostrado una técnica muy novedosa y excelentes resultados postoperatorios. Me gustaría dar la palabra a nuestros panelistas a fin de que si tienen alguna pregunta o algún comentario, se lo transmita al doctor Fessler. Por favor, adelante.
Jaime, ¿me permite la palabra?
Por favor, ten la bondad, Jorge.
Gracias. Primero, felicitar y agradecerle al doctor Fessler esta conferencia. ¿Por qué felicitarlo? Porque es que cada vez que lo oigo, aprendo algo de él, comparto 100% los conceptos de todas las bondades de la cirugía de mínima invasión. Llevo 28 años haciéndola, también como pionero en América Latina, y él es el pionero en los Estados Unidos. Decirle que América Latina, y hoy específicamente la SILACO, tenemos un reconocimiento muy grande por él, por todo lo que nos ha aportado. Él fue presidente de la SIDNI, primer americano en serlo, que es la Sociedad Interamericana de Cirujanos de Mínima Invasión, como lo fue el doctor Soriano y el que les habla. Fuimos también presidentes y fundadores de esta sociedad. ¿A qué viene todo este cuento? A que sí, el doctor Fessler ha aportado muchísimo al continente latinoamericano con sus técnicas, entrenando gente en Estados Unidos y estando en varios países de América Latina mostrándonos su experiencia, y hoy lo estamos viviendo con la SILACO. Entonces, mi comentario, doctor Feller, es nuevamente agradecerle. Sigamos en esta línea. Ya hoy en día la evidencia demuestra que sí teníamos la razón. Hace muchos años, 28 años que yo comencé, hablaba en algún lado y me miraban como un loco mentiroso que estaba diciendo cosas que eran imposibles. Hoy en día estamos demostrando que sí se puede. Todas las bondades de lo que usted dice, comparto perfectamente. Y gracias, América Latina es su casa, la SILACO lo mismo. Y lo único que necesitamos es generar más centros de entrenamiento, tanto en Estados Unidos como en América Latina, para seguir formando gente en estas técnicas, porque definitivamente no son el futuro, son el presente. Gracias, Jaime, y gracias, doctor Fessler.
Bien. Doctor Fessler, ¿algún comentario al respecto? O los panelistas?
Yes, thank you, Dr. Leon. You are very kind in your statements. It is a pleasure for me to be with you and the other international pioneers in minimally invasive surgery. I will admit I have one major failure, and that is that I've been trying to learn adequate Spanish for a number of years, and I have totally failed. But thank you for allowing me to be such close friends with so many of you. It's been my honor.
Andrés, por favor.
Buenas tardes, doctor Fessler, doctor Ulloa de España. Quería hacerle un par de preguntas, comentarios. Bueno, primero agradecerle la conferencia que ha sido muy claramente expuesta. En primer lugar, quiero decir que creo haberle entendido, y yo estoy plenamente de acuerdo, que los abordajes laterales no es tan bueno hacerlos percutáneos. Es mejor abrir un poquito y ver a veces hasta el borde lateral del psoas para evitar problemas. Lo he entendido bien, ¿no? Yo comparto ese criterio. Fessler?
Absolutely. Absolutely, I agree. It's very important. There are now what they're calling the oblique approach as well, where you go anterior to the ventral insertion of the iliopsoas, and by doing that, you can even avoid the femoral nerve a little bit better. And I think that's a fine approach, but you can also achieve the same thing simply by putting your finger down onto the iliopsoas muscle and pulling the bulk of it back, and then going through the very ventral part of it. And by doing that, I really have rarely had any problem with the femoral nerve.
Gracias. ¿Puedo hacer un segundo comentario, Jaime?
Por favor, adelante.
A la hora de tratar la unión lumbosacra, ha comentado que un cajetín solo de un TLIF da poco soporte y hay veces que realmente ves que te quedarías más cómodo o más tranquilo haciendo una LIF, pero eso logísticamente supone dar vuelta al paciente y muchas veces el estándar es el TLIF. He visto que usa pocos tornillos ilíacos. Entonces yo le quería preguntar, ¿a partir de cuántos niveles aconsejaría hacer ALIF L5S1 en vez de TLIF? Y si habría algún lugar, a lo mejor un TLIF apoyado en ilíacos, podría dar un resultado similar a ALIF. Gracias.
That certainly is one of the possible solutions. The only time I do a TLIF now is if there is a contraindication to doing an ALIF. If, for example, the patient has had multiple bowel operations and the approach, or they have had bypass surgery of their iliac artery or vein, and you would not be able to get adequate exposure of the ventral vertebral body and disc space. Otherwise, I will always do an ALIF. We found that our reoperative rate is higher if we go directly to the iliac wings. So I prefer not to do that. I have done a few salvage operations. There were failed TLIFs, actually, in patients that did not fuse L5S1 and then had loosening of their screws in S1. And in those cases, we supplemented it with an ALIF and iliac wing screws. But I prefer not to go to the iliac for the two reasons. The one is there's a higher reoperative rate. And number two, going through the iliac wings really does restrict the patient's movements much more than ending at S1. It becomes very difficult for them, for example, to get in and out of a car. So I prefer not to go to the iliac wings if I can avoid it.
Gracias. Muchas gracias.
Jaime, ¿puedo hacer una pregunta?
Por favor, Alejandro. Adelante, Alejandro.
Doctor Fessler, un par de preguntas relacionadas con la corrección de la escoliosis a nivel torácico. Una de ellas es si tiene o cómo es la técnica de corrección cuando hace ostomías y tornillos pediculares, ya que todas las estructuras de la línea media están en su lugar, y si tiene algún punto de corte en los cuales decide si ese paciente es candidato a corrección mínimamente invasiva o a cirugía abierta, ya sea la dimensión de la curva, la rigidez o algún factor que usted considere.
I haven't done an open correction of thoracic scoliosis in the last 5 to 6 years. My technique is to dilate through the muscles, and I'll either use a tube or I will just use nasal speculum that we get from the ENT doctors. Dilate down to the facet at each level bilaterally and drill out the facet itself. That mobilizes the spine just by doing that. Then I will pack a little bit of bone and a quarter sponge of BMP into the facet, and then I just do percutaneous screws and rods and use the rods to correct the curve. And by doing that, I've had really excellent results. My patients have been very happy.
Ok, ¿y tiene alguna limitación o algún punto de corte en pacientes con curvas de cierto valor angular o de cierta rigidez, o es su elección siempre la corrección MIS?
I always do MIS. Now, it is possible that in coming years, I will learn that there are limitations as I keep trying to push the envelope. I might come into cases that I fail on. So far it's been okay, but I'm sure I'll find a limitation somewhere.
Thank you very much.
Jaime.
Perfecto.
Jaime, ¿puedo hacer una pregunta? Doctor Fessler, Julio Rutia de Chile aquí. Usted comentó que una de las limitaciones para poder hacer la cirugía mínimamente invasiva era que los pacientes tuvieran un SBA normal. ¿Cómo valora el que el paciente pueda tener o no mecanismos compensatorios que le permitan tener un SBA normal versus que no los tenga?
Patients that do or do not have a normal SVA.
La pregunta es, si no tienen un SBA, o sea, si los pacientes que tienen un SBA normal, pero que están usando mecanismos compensatorios, ¿puede ser también una limitación para poder hacer una técnica mínimamente invasiva?
No, it's not so much a restriction on the use of minimally invasive technique as it is to understand their compensatory mechanism. For example, if they are bending their hips in order to get back to a new SVA, then you have to make sure that they don't have so many constrictures that even if you correct their scoliosis, they're still going to be bending forward, because then you would actually decrease, you would make their imbalance worse if you don't correct that. So it's very important to get full standing x-rays from the head to the feet, which we are now able to do, so we can evaluate what's going on with the hips and what's going on with the knees, which may be affecting how they, may be compensating for their SVA.
Okay. O sea, usa radiografía no de columna completa, no el espinograma completo, sino que de cuerpo y que incluya las extremidades inferiores.
That's correct.
Rick, ¿puedo hacer una pregunta, Jaime?
Por favor, adelante, José Antonio.
Creo que una de las cosas más importantes que he escuchado de la plática de hoy es la situación en la que comparado con la corrección agresiva de la escoliosis, lo más importante es el efecto clínico. Y tú claramente mencionaste en tu charla que muchas veces el corregir, especialmente en pacientes añosos, el corregir la curva de manera agresiva no genera mejores resultados clínicos. Entonces aquí el punto que yo quisiera marcar para la audiencia es la importancia de la búsqueda de las mejores condiciones clínicas y no de las mejores condiciones trigonométricas del paciente. Creo que ahí está el punto donde hay que estudiar más para saber hasta dónde exactamente se deben de corregir los pacientes y no necesariamente perseguir resultados aparatosos que luego resultan también en unas incidencias de complicaciones bastante aparatosas, porque 45% de complicaciones mayores, Dios mío, es un volado. ¿Es así, Rick?
That's true, and that's only major complications. If you include minor complications in open surgery of correction of scoliosis, the complication rate is above 80%.
Yo pienso que eso es prohibitivo. Prohibitivo.
Una pregunta
80%.
corta.
Por favor, Alejandro, ten la bondad.
Doctor Fessler, ¿qué tipo de biológicos usa habitualmente en la vía anterior y en las vías laterales?
Because we aren't harvesting bone for that, I don't get to use autologous bone. So I will use one of the hydroxyapatite formulations. I think, for example, one of them is called Master Graft. It comes in a little cylinder. I'll use that. And I'll use just 1/2 of a sponge per level of bone morphogenic protein. So I don't use a lot of BMP. You don't have to. All it has to do is induce a response. Once the response is induced, the body takes care of everything itself. So you don't need a lot of it. I use a very little bit at each level. And they are now coming out with some nanotechnology bioglass polymers that are looking very promising. I've tried that in a few cases, and now I'm watching that to see how effectively they will fuse. It's less expensive than BMP. And by doing it, you only need to use one thing. I don't have to use hydroxyapatite and BMP. I can just use these biopolymers, and it'll be a lot cheaper if they turn out to be working well.
Right. Thank you. Thank you very much.
Bien, yo tengo una pregunta para el doctor Fessler. ¿Qué consideraciones toma usted en el paciente que tiene osteoporosis desde el punto de vista de planeación quirúrgica y de técnica quirúrgica en sí mismo?
That's an excellent question, because they can be so problematic. There are some patients that I simply won't operate on. If there are 3 standard deviations away from normal, that's my cutoff. I will not do scoliosis surgery, and I won't do most surgery on a patient that is that osteoporotic. If they're 2 or less, then I really don't take any additional measures other than using, for example, the longest screw that I can, and trying to get as much of an end plate cover with my cage as I can to try and maximize the support. But my cutoff is at 3, and I also have a cutoff on morbid obesity, because morbid obese patients usually are malnourished, and their bones are usually very weak. So if a patient comes in at a BMI of 40, for example, I will refer them to our clinic to help them lose weight, but I will not operate them until they do. And my other cutoff is smoking. If they smoke, I will not do a scoliosis operation on them.
Gracias, doctor Fessler. Hay una pregunta del doctor José Luis Miguel Duchenne de Bolivia, que le pregunta si es posible realizar con el paciente en decúbito supino la cirugía tanto de colocación de cajas intersomáticas por vía lateral para evitar mover al paciente el momento de hacer la instrumentación posterior. ¿O usted cree que la colocación de cajas por vía lateral con el paciente en decúbito supino es una técnica que no recomendaría.
Some people are doing that. I think you really have to be very skilled to do that. One of the problems, of course, is in that position, the bowel is going to be falling into your surgical field, and you're going to have to be very careful on your approach not to get a bowel injury. I've heard of people doing that. I've seen videos of people doing it. I haven't done that myself. Yeah, I can turn the patient and reprep in 20 to 25 minutes, and I don't find that to be a big inconvenience. So I probably am not going to start doing that myself, but I think it would be a great thing, particularly for younger surgeons, to jump on and make it a safe procedure.
Gracias. Vamos a pasar ahora a la presentación del caso clínico por el doctor Sergio Soriano. Doctor Fessler, muchas gracias nuevamente por su conferencia y su participación, al igual que a todos los panelistas, muy amables. Sigamos entonces con el doctor Sergio Soriano y la presentación de su caso clínico. Sergio, ¿me escuchas?
Sí, doctor.
Perfecto. No te vemos.
No tengo lamentablemente cámara en este momento, pero sí tengo el micrófono y la presentación. ¿Ven mi pantalla?
Sí, perfecto.
Ok. Bueno, pues muchas gracias a Silaco por la invitación a esta presentación de caso clínico. Vamos a empezar. Se trata de un masculino de 67 años, de antecedentes de importancia, hipertensión arterial y uso crónico de aspirina. Su padecimiento actual, un año de evolución con dolor lumbar irradiado a las nalgas de forma bilateral, con un acné de 10 de 10 tipo urente, irradiado a la cara externa de la pierna y dorso del pie derecho, acompañado de adormecimiento y hormigueo, así como deformidad progresiva. El dolor se exacerba a la bipedestación y presenta también claudicación neurogénica a menos de 100 metros. El dolor disminuye parcialmente con la ingesta de gabapentina y tramadol. Y bueno, tuvo 8 semanas de tratamiento conservador con fisioterapia, antiinflamatorios y demás medicamentos sin mejoría importante. Refiere un deterioro importante en su calidad de vida, tuvo un Oswestry de 60%. Y en las últimas 3 semanas con dolor similar agregado en el miembro pélvico izquierdo. Al examen físico con una rotoscoliosis levoconvexa, dolor a la flexoextensión y flexión lateral derecha en región lumbar, dolor a la palpación paravertebral de predominio izquierdo DL1S1 y una paresia de cuádriceps y la dorsiflexión del lado derecho 4 de 5, 4 menos de 5 para dorsiflexión izquierda y 4 de 5 para flexión plantar izquierda, así como 4 más de 5 para la flexión plantar del lado derecho. Asimismo, hipoalgesia en dermatomos L3 derecho y L5 izquierdo, y los reflejos con arreflexia del patelar derecho y disminuido el aquileo bilateral. Estas son las radiografías preoperatorias, AP lateral y dinámicas, donde podemos observar olistesis múltiples, una olistesis L2, L3 a la derecha, una olistesis L4, L5 a la izquierda muy importante y una retrolistesis en el lateral móvil 3-4. Vemos en la tomografía los cambios importantes de esclerosis, aire intradiscal prácticamente en todos los discos lumbares y las olistesis muy claras en las radiografías. En estos cortes axiales observamos en el nivel L1-2, bueno, no vemos mayor compresión. En el nivel L2, L3 tampoco. En el nivel L3, L4 sí. Del lado derecho, una importante estenosis del receso lateral, condicionada por la hipertrofia facetaria y un espondilofito. Y en el nivel L4, L5, igual sin mayor compresión. Y en el nivel L5-S1 del lado izquierdo, igual una estenosis importante del receso lateral izquierdo con una hipertrofia facetaria Grogan 5. Estas son las radiografías tridimensionales donde podemos observar la complejidad de la deformidad que tiene este paciente. La densitometría ósea, cabe mencionar, fue normal, 1.2 desviaciones estándar en comparación con el adulto joven, su T-score, y el Z-score 134%. En cuanto al balance sagital, inicialmente un balance ligeramente negativo, un SBA de menos 1.5, y el mismatch de la incidencia pélvica y la lordosis lumbar de 33.2, una incidencia pélvica alta de 67.38. Entonces, los diagnósticos que integramos fue una escoliosis degenerativa del adulto con estenosis de los recesos laterales L3, L4 derecho y L5, S1 izquierdo, secundaria hipertrofia fascietaria, repliegue del ligamento amarillo. Olistesis L2, L3 a la derecha, L4, L5 a la izquierda y L5, S1 a la derecha. Retrolistesis móvil L3, L4 y radiculopatía L3, L4 derechas y L5, S1 izquierdas. Nosotros utilizamos inicialmente este algoritmo realizado por el grupo del doctor Muaneni, y de acuerdo a este algoritmo, si lo seguimos, el paciente tiene un SBA de menos de 6 centímetros, una incidencia pélvica de menos, aquí ya no es de más de 25 y se irá directamente a una clase 3 que sugiere cirugía abierta. Abro las preguntas a los panelistas sobre el caso.
Perfecto, muy amable, Sergio, muy interesante el caso. Me gustaría dar la palabra a nuestro grupo de panelistas y al doctor Fessler si quieren hacer un comentario sobre este caso en cuanto al diagnóstico y en cuanto a las opciones de tratamiento.
That's a very interesting case. And you're right, the original algorithm of what's called MISDEF would have made that a class 3 case to do open. I think our newer classification puts it in that category where if you're an experienced minimally invasive deformity surgeon, you could do it minimally invasive, but if you're not, you probably want to do it open. In my hands, I'm glad you summarized the case at the end, because I was wondering how much was back pain and how much was radiculopathy and what levels was the radiculopathy at. I think in this case, I was hoping to make, if she only had a 1-level radiculopathy, perhaps just a little foraminotomy would relieve her of her pain. But given this diffuse radiculopathy with a lot of back pain, I think we're stuck doing the whole thing. And the real question is then, do you go to the sacrum and do you go up to L1? Because L1 wasn't bad, but there was vacuum phenomenon. So I think in this case, I would go L1 to the sacrum. I would do L4-5 and L5-S1 through an ALIF with hyperlordotic cages. I would do 3-4 and 2-3 through lateral. And at L1-2, I would just do a facet fusion. And then I would do L1 to S1 posterior instrumentation, trying to get her within 6 centimeters of sagittal deformity. Her sagittal balance isn't too bad, but we want to keep her within 6 centimeters or as close to 0 as we can.
Excelente observación, doctor.
Perfecto, gracias. Muy amable, doctor Fessler. Alejandro, ten la bondad, ¿alguna pregunta o comentario?
Era un comentario para el doctor Fessler, una pregunta, de hecho. En los casos en los cuales, globalmente, en general, y especialmente enfocados en el nivel 4 o 5, si la anatomía quirúrgica es favorable, la elección de él es un abordaje anterior al psoas tipo LIF o trans-psoas, en casos de anatomía favorable para ambos métodos.
It depends upon the level. At L5-S1, you can always get a very easy anterior approach. L4-5 can be more difficult, but most of the time we can mobilize the vessels well enough. 3-4 can be problematic, and 2-3 is sometimes really problematic because the aorta and the vena cava are laying right on the front of the vertebral bodies. So in those cases, it's safer to go lateral. So most often, I will do 4-5 and 5-1 anterior, and I will do 3-4 and 2-3 lateral.
Jaime, me gustaría hacerle una pregunta al doctor Fessler.
Por favor, Julio.
Sí, en este caso, además de la estenosis foraminal que tiene el paciente y de la escoliosis y las laterolistesis, El paciente tiene un mismatch entre la incidencia pélvica y la lordosis lumbar, y aquí deberíamos tratar de corregir casi 30 grados de lordosis. La pregunta es, ¿hasta cuántos grados de lordosis puede obtener por técnicas mínimamente invasivas? ¿Hasta cuántos grados puede corregir sin tener que recurrir a una osteotomía, por ejemplo, sustracción pedicular? O sea, ¿cuánto puede corregir por técnicas mínimamente invasivas?
Doctor Fessler, por favor.
We add up each individual level, and I typically assume I will get half of whatever lordotic cage I'm putting in. So if I'm putting in a 25 degree lordotic cage, I will expect to get about 12 to 13 degrees. So if I do that at two levels, if I do that at 5.1 and 4.5, I will have corrected nearly 30 degrees already. Okay. So we can get 30 to 40 degree mismatch now by using the hyperlordotic cages and by bending the rods in that push-through technique that I described.
Perfecto, gracias.
Jaime, ¿puedo hacer otra pregunta relacionada con el planteo del doctor Fessler?
Por favor, adelante, Alejandro. Ten la bondad.
Doctor Fessler, en estos casos en los cuales plantea un abordaje en múltiples niveles, por una vía alif y una vía lateral, en general comienza de cefálico a caudal, en el ápice de la curva, o cuál es su preferencia y su elección en múltiples niveles cuando combina vías laterales con otros procedimientos?
I will always start with the ALIF first, and that is not because I think you have to do that. It's because the general surgeon that I work with for the approach has to do it first in the morning. So okay. I always do L4-5 and L5-S1 ALIF first. Then I will flip to the lateral and do 3-4 and 2-3, and I usually go from 3-4 to 2-3 because 2-3 gets to be a more difficult level. And then I will usually stop for the day. And then, for example, that might be a Monday. And then on Tuesday, I will get new standing scoliosis x-rays so that I can see how much more I have to accomplish. And then on Wednesday, I'll go back and do the posterior part and try to get the rest of the correction that I need. Most of the time, the majority of correction that I need is already done from the anterior part.
Quisiera hacerle otra pregunta al doctor.
Muy bien.
Doctor Moyano.
Por favor, Jorge, ten la bondad.
Gracias, sí, no. Primero, felicitar al grupo del doctor Soriano por traernos este caso tan interesante, tan bien estudiado y estoy seguro también resuelto. Y seguro que con técnicas de mínima invasión, porque pues eso es lo que ellos hacen y pues para eso tenemos el webinar de hoy. Yo, viendo muy bien el caso, pues yo soy cirujano endoscopista de mínima invasión y miraba y decía, bueno, si el dolor fuera netamente radicular, yo pensaba en hacerle un procedimiento endoscópico con cajas standalone asistidas por endoscopio, pero es que el paciente, además del dolor radicular, tiene un dolor lumbar muy severo, por lo cual hay que verlo integralmente y comparto perfectamente con las apreciaciones y la del doctor Fessler en hacerle un procedimiento en dos tiempos. En el primer tiempo yo pensaría pues en unas cajas laterales y en un segundo tiempo sí una instrumentación pedicular con una técnica de mínima invasión, como él nos lo mostró, en lo que está haciendo en un lapso de 48 horas. Pero yo sí quisiera, y lo estaba mirando por todos los ángulos, cómo lo podía resolver endoscópicamente, pero no. Es un caso muy complicado en donde no me atrevería a resolverlo por los dos componentes que tiene tanto el dolor radicular como el dolor axial, por llamarlo así, lumbar. Gracias.
Bien, gracias, Jorge. Julio, por favor.
Sí. Quería hacerle otra pregunta al doctor Fessler. La descompresión foraminal, en este caso, ¿usted la haría fundamentalmente a través de la recuperación de la altura con el uso de los cages o además haría descompresiones por vía posterior endoscópica? Vale, si foraminotomías.
In this case, I think we will adequately decompress the foramen just with the cages. Occasionally, I've had to go back and do a foraminotomy because it wasn't adequately relieved. But most of the time, just the cages themselves, with this amount of foraminal stenosis will adequately decompress it.
Okay.
Muy bien. Vamos a pedir al doctor Sergio Soriano que nos muestre el resultado de este tan interesante caso. Por favor, Sergio.
Gracias, doctor. Ok, entonces, este caso lo que planeamos fue efectivamente una resolución en dos tiempos. En el primer tiempo, nosotros decidimos sí hacer L1, L2, como lo comentaba el doctor Fessler. Un abordaje extremo lateral, L1, L2, 2, 3, 3, 4, 4, 5, del lado derecho. Y las cajas que se utilizaron fueron 22. Y en el segundo tiempo quirúrgico, que fue 48 horas después, hacer una fusión intersomática lumbar extremo lateral, L5S1, y perdón, extraforaminal, y una facetectomía L5S1 izquierda, y complementar con instrumentación transpedicular solamente de L3 a S1. Este es el resultado posoperatorio con la descompresión indirecta de las cajas hasta L4. Vemos nosotros aquí en la tomografía, estas son las cajas, perdón, en las proyecciones vemos la instrumentación de L3S1 y las cajas standalone en 1, 2 y 2, 3. Consideramos como el paciente tenía una densitometría ósea normal, dejarlas standalone y instrumentar solamente de L3S1. Eso fue lo que decidimos. Estas son las grafías dinámicas. Y el mismatch postoperatorio que obtuvimos fue de 10 grados. En realidad se mejoró mucho el balance sagital con esta técnica. Vemos ahí igual las reconstrucciones tridimensionales, cómo mejoró también parcialmente el COP coronal. No sé si tengan alguna pregunta o algún comentario respecto a la cirugía.
Perfecto. Perdón.
Very nice job, Sergio. Very nice.
Perfecto. Se ve una gran corrección del balance sagital. La instrumentación posterior, por favor, me repite, Sergio, ¿la hiciste la transpedicular de qué nivel a qué nivel?
L3 a S1.
Perfecto.
Y les muestro el video preoperatorio versus el posoperatorio de cómo, inmediato al día 0, de cómo caminaba el paciente y cómo camina después de la tarde del día del segundo tiempo quirúrgico, ¿no?
Sí, se aprecia que tiene una importante descompensación coronal que se corrigió totalmente, a más del desbalance sagital.
Sí, creo que el resultado fue pues, bastante bueno y sobre todo clínicamente a 2 años refiere a una mejoría en el Oswald Tree de un 60% que tenía a 20%.
Perfecto.
Jaime.
Sí, ¿alguna pregunta, algún comentario?
Para Sergio, que bueno, creo que el resultado es, el video habla claramente de la mejoría del paciente. Quería preguntarle si podría compartir con la audiencia cuáles son sus criterios de selección para cajas standalone. Creo que sería importante compartirlo con nosotros.
Por supuesto. Sí, el criterio más importante que utilizamos, siempre tratamos de usar las cajas más grandes posibles, ¿no? Solamente que sean pacientes en donde las vértebras están más pequeñas, se merita una caja más pequeña, bueno, pues las utilizamos. Y el otro criterio más importante es la densidad mineral ósea, que sean pacientes que tienen una densidad normal. Igual opinamos igual que el doctor Fessler, en pacientes que tienen osteoporosis severa, pues no podemos ofrecerles muchos tipos de procedimientos. Igual preferimos no operarlos por la mala calidad ósea.
Perdón, Sergio, una pregunta, Julio Ruti acá. Pero
Sí,
añadiendo a la pregunta de Alejandro, ¿cuándo usar standalone cages? O sea, ¿cuándo usar caja standalone? ¿Y por qué en este caso no usar la instrumentación, no extender la instrumentación hasta L1, ya que está fusionado?
en este caso, decimos no hacerlo hasta L1 porque dejamos la unión tóraco-lumbar ahí con un mayor, digamos, una mayor propensión a futuro a tener degeneración. por esa instrumentación limitada L1. Más bien hubiéramos pensado si nos hubiéramos subido quizás tomar la unión toracolumbar, pero creímos prudente no hacerlo por la buena calidad ósea y dejar las cajas standalone, los cuales hemos tenido buenos resultados en la parte lumbar alta.
Sí, Jorge Ramírez. Sergio, para mí, muy bien resuelto. La pregunta es, ¿cuánto tiempo lleva de seguimiento y cómo ha sido la evolución? Porque yo creo que eso es lo que nos dice definitivamente si las cajas están alón, tenían la indicación o no, no haber subido la instrumentación a L1. Yo quisiera ver un poquitico sobre el seguimiento de este paciente. Gracias.
Sí, hasta el momento el paciente lleva, bueno, va a venir a su cita de 2 años de seguimiento. A los 18 meses que fue la última cita tenía un post-Westry de 20% y a los 2 años solemos tomarles ya todos los estudios de seguimiento, tomografía, radiografías dinámicas y todo para valorar, pero clínicamente el paciente a los 18 meses estaba bastante bien.
Bien, yo tengo un comentario. Es muy interesante ver en este caso que la instrumentación posterior es L3-S1, pero la fusión intersomática anterior proximalmente se extiende hasta lumbar 1. Me da la impresión de que tal vez esta estrategia puede disminuir el riesgo de un PGK o de un síndrome de segmento adyacente a futuro, tomando en cuenta de que una de las causas del PGK son una osteosíntesis muy rígida o el daño de partes blandas que uno infligiría al realizar la instrumentación transpedicular posterior. De tal suerte de que, no sé, me gustaría conocer la opinión del doctor Fessler de si esta podría ser una estrategia para disminuir el riesgo del PGK o no.
That's a very interesting question. I personally, early on when I used anterior-only constructs, I had several failures right away. So I no longer do unsupported anterior interbody fusions. I always put in screws. There is some evidence that putting these cables, flexible cables, on top of a long construct has decreased the incidence of PJK to some extent. And if it's possible that an unsupported anterior interbody fusion could achieve the same result. But on the other hand, if you get a solid fusion, then there's going to be nothing preventing the adjacent level from wearing out at the same rate because you have no motion with a fused segment. That's a very interesting question to which I don't know the answer.
Bueno, muy amable. Sí, es un punto en que realmente todavía hay mucho que investigar y entender sobre el síndrome del segmento adyacente y la cifosis de unión proximal. Me gustaría, Sergio, conocer si tienes alguna otra imagen, diapositiva más o algún comentario, algo adicional que desees decirnos tú en este momento.
No, en realidad era prácticamente la última diapositiva, eran las imágenes clínicas de las cicatrices. Creo que fue un caso bien resuelto, igual como dice el doctor Fessler, creo que vamos eventualmente a encontrar las limitaciones de la mínima invasión y pues dar las gracias al doctor Fessler por su presencia y el interesante algoritmo que nos mostró ya mejorado, ¿no?
Perfecto, muy amable, muchas gracias Sergio, muy interesante tu caso y un gran complemento para el tema tratado el día de hoy. Me gustaría transmitir algunas preguntas de la audiencia. Tenemos una pregunta de la audiencia que nos indica si el esquema terapéutico de analgesia postoperatoria es menor en cuanto al esquema terapéutico de analgesia en las cirugías abiertas. Y en general, ¿cuál esquema de analgesia utiliza usted, doctor Fessler, después de estas cirugías en los pacientes?
my analgesia postoperatively for the first night and sometimes for 2 nights will be patient-administered IV narcotics, morphine usually. And then I will switch them to an oral narcotic like Tylox, for example, along with a muscle relaxer. I don't use nonsteroidals in the first 6 weeks, but after that, I'm comfortable using them. If they were coming in on heavy narcotics to begin with, then I will usually get our pain management team involved right away so we can do our best. Not so much for scoliosis right now, but for for our lumbar fusions and our discectomies and stenosis, we are trialing a new type of anesthesia where preoperatively or just after we induce anesthesia, our anesthesiologist will do a number of blocks of the nerves in the region. So he will do high volume, low concentration blocks all along the paraspinal muscles in the region where we're going to operate. And this has taken our pain medication requirements down more than 50%, and even our fusions, our 1-level fusions now are ready to go home the same day of surgery. It's had a remarkable effect. So it's combining regional anesthesia with oral anesthesia.
Muy amable, doctor Fessler. Muy clara la respuesta. Por favor, Alberto, ten la bondad.
Buenas tardes. Nuestros anestesistas nos han hablado de este tipo de bloqueos en la musculatura paravertebral, pero a mí siempre, además, hechos preoperatoriamente, antes de abrir. Pero en la discusión, yo como cirujano siempre me da como un poco de reparo, de miedo, el operar y disecar y dejar un músculo como más encharcado, como más desvitalizado. Veo que usted no tiene esa preocupación, o sí, o cómo lo han discutido eso. ¿Entiende?
Dr. Fessler.
Yes, yeah, the question is clear. We have not had any complications at all with this, and I'm frankly shocked at how effective it is. So we tried it experimentally with just a couple of us, but now we're expanding it to all of the surgeons that are doing spine surgery in our department. It's really been pretty impressive.
Gracias.
Muy amable. ¿Alguna pregunta adicional de los panelistas? Julio,
solo comentar que en mi hospital también usamos este bloqueo de la musculatura paraespinal preoperatoria y efectivamente nos permite disminuir el uso de analgésicos. No todos los anestesistas lo hacen, pero cuando lo hemos usado es realmente efectivo. No tenemos ninguna tabulación al respecto, pero sí lo hemos visto como algo efectivo.
Jaime, ¿puedo hacer una pregunta con respecto al caso anterior, al doctor Fessler?
Por favor, Alejandro.
En el caso anterior se hizo un abordaje al disco L5-S1 con la resección solamente de la faceta ascendente, un abordaje tipo ILIF. Quisiera saber cuál es la experiencia y la preferencia con respecto concretamente al espacio L5-S1 para los abordajes, si trabaja cómodo a través de una resección tipo ILIF, si en su experiencia es mejor resecar ambas facetas, siempre considerando la anatomía de la raíz de L5, ¿no?
I think my preferred approach, if I can do it, is anterior, is an ALIF. If I'm going posterior and it's just a single level, then I'm comfortable doing just a unilateral cage through an ELIF or a TLIF. And as long as there's no spondylolisthesis, then the L5 nerve root usually isn't an issue. When there is a grade 1 or more spondylolisthesis, then as you know, the L5 nerve root can be draped right over the disc space where you have to work. And in one case, I even had to abandon the procedure because there was just no way to safely get into the disc space. If I'm going to be at the bottom of a long construct and I cannot do it I cannot do L5S1 from the front, then I would do bilateral cages through the TLIF approach. because you just need more support than you can get through a unilateral cage. Although that may not be true in the future. There are some cages being developed now that will give you the same size cage as an A-lift, but done through a T-lift. And when those cages can become universally used, I think then doing a T-lift will become a reasonable operation at the bottom of a long construct once again.
Thank you.
Doctor Fessler, en relación a las cajas intersomáticas, ¿usted encuentra alguna diferencia entre las cajas de PIC y las cajas de titanio o esencialmente cumplen la misma función?
I can't answer that question because I don't use titanium cages at all. I think the fusion rate will be just as good or maybe even better than a PIC cage, but I don't like the imaging characteristics of titanium in the interbody space. I can't tell if I've got a fusion or not, whereas with PIC I can. So I still, although many people will call me a dinosaur, I still only use PIC. I don't use any titanium.
Yo tengo una pregunta al Dr. Fessler.
Sí, yo utilicé unas pocas veces la de titanio, pero realmente me siento más confortable con las cajas PIC por el mismo motivo. Es más clara para mí la interpretación radiográfica en el postoperatorio.
Jaime, ¿puedo un comentario para el doctor Fessler?
Sí,
doctor Fessler, el comentario es sobre el tema de costos, que usted muy bien lo mostró, lo que se ahorra en costos en los procedimientos de mínima invasión. Y lo hago específicamente porque todavía en algunos países de América Latina los servicios de salud no pagan los procedimientos de mínima invasión porque dicen, entre comillas, que es más costoso. Pero es que usted nos mostró claramente el ahorro que se presenta con los procedimientos en la parte, llamémosla quirúrgica, costos de hospitalización, estudios y de honorarios. Pero en el global, eso es una tercera parte, porque 2/3 partes de los costos la generan lo que llamamos incapacidades. Tanto tiempo físico de ausencia como regresar al trabajo, adaptarse al nuevo trabajo que tiene que hacer o muchas veces reubicarlo. Y eso son 2/3 partes. Tengo entendido que en Estados Unidos es lo mismo que en los países de América Latina. ¿Qué opina sobre esto? Es simplemente para decir que lo que se ahorra en costos un paciente con mínima invasión versus abierta es muchísimo, mucho más que lo que vemos solamente por lo que vale la clínica. Gracias. O la hospitalización.
I think you're absolutely right. We save on both ends. The procedure is less expensive because the hospitalization is shorter and their use of ancillary facilities is shorter. And we save on the other end because they get back to work much more quickly. Now, I will also preface that by saying I no longer do workers' compensation cases in the United States because there is an incentive for those patients not to go back to work because they get paid a good living by not working. So, you know, I know that I cannot get honest answers from them. I will never get good results because they are incented to stay off work. So I simply stopped doing that group of patients.
Jaime, creo que Hani tiene una
Muchas
pregunta,
gracias.
pero
Me
no sé por qué no está
gustaría dar la
funcionando.
bienvenida y la palabra al doctor Hani Mahidli, que es nuestro presidente de la Sociedad Ibero-Latinoamericana de Columna. Por favor, Hani, adelante.
Gracias, doctor Fessler, gracias a todos por el interesante tema. La pregunta es práctica. Doctor Fessler, aunque sea para un solo nivel de fusión, ¿sueles pedir radiografías enteras de la columna para tener en cuenta los parámetros espinopélvicos o no lo miras? Aunque sea para un solo nivel de fusión.
Doctor Hani, ¿puede repetir la pregunta de nuevo? Algo pasó con el sonido, por favor.
¿La hago en inglés?
Puede ser, sí, por favor, Hani.
Dr. Fessler.
Yes, I hear you.
Yeah, in English. So my question is, even if it is only for one level fusion.
I can hear him.
You hear me?
Not anymore, no.
¿A mí me escucha, Dr. Fessler? Could you hear me?
I can't hear him, no.
Okay.
I heard him at first, and then it went out again. I lost it.
Now, do you hear me now?
I hear you now.
Okay. The question is, if you want to fuse only one level, do you look at the spinopelvic parameters or not?
Yes, but not because I think I need it. When my patient is coming to me as a new patient, the standard x-rays I get are full scoliosis x-rays and lumbar x-rays. So I have that available to me, but if they look like they have normal balance, I don't measure it. And the reason I do that is because, the reason I get scoliosis x-rays right away is because so many of my patients come in with scoliosis, even those that don't need scoliosis correction, that I can take care of them more efficiently if they get their x-rays before they come, rather than looking at their lumbar x-rays and saying, uh-oh, we need scoliosis x-rays, go back downstairs and get scoliosis x-rays. So everybody just gets them as part of their incoming package, and then I can evaluate everything right there and then and give them an answer without having to send them all over the hospital.
So I understand that you always ask for a full standing AP and lateral x-ray.
Correct.
It's a good message for all. I mean, I have seen some surgeries without any x-ray, only MRI.
For that would be below standard of care, and I'd get sued in the United States.
Sí, yo pienso que actualmente es muy importante tener la imagen panorámica de la columna, precisamente como una forma de, a largo plazo, disminuir el riesgo de afecciones que alteren el balance sagital. Ahora vemos que incluso a veces las radiografías dinámicas son importantes, o poner la imagen en pie con la imagen del paciente acostado. Muchas veces en pie vemos una grave deformidad y acostado, sea en la tomografía o resonancia, desaparece esa escoliosis, que muchas veces tiene un gran componente antiálgico, lo cual en la preparación de nuestra estrategia quirúrgica nos indica que el procedimiento puede ser menos complejo de lo que con una radiografía en pie estaríamos pensando. Me gustaría saber si hay alguna pregunta adicional al momento. Bien.
Sí, por ejemplo, en México, Jaime,
¿sí?
Como no es un estándar que esté reportado en las guías internacionales, guías clínicas de manejo y tratamiento, muchas veces los seguros no te quieren pagar una radiografía panorámica, AP y lateral por lo menos, porque no está en el estándar de cuidado actual. O sea, sí entiendo esa postura, pero tal vez estamos exagerando un poco. Yo creo que si el paciente no tiene una sospecha de escoliosis clínica, no está justificado definitivamente.
Sí, de acuerdo. En caso de escoliosis, pienso yo que sí, pero por supuesto, si el paciente no tiene escoliosis, totalmente de acuerdo, José Antonio. Me gustaría pues agradecer a todos los participantes, doctor Fessler, y todos los participantes por este excelente webinar, un tema sumamente interesante, actual, de una patología que cada vez va a ser más frecuente. Realmente todas las opiniones y comentarios que se han vertido han sido de mucha importancia y de mucha enseñanza para todos nosotros. Y me gustaría dar la palabra al doctor Mahildi para que haga el cierre de este webinar. Adelante, por favor.
Muchas gracias, doctor Moyano. He de agradecer al doctor Fessler por su tiempo y su magnífica charla que ha aprendido. A todos los panelistas también su participación y, como no, al doctor Soriano, que ha hecho todo lo posible para hacer este webinar junto contigo, junto con el doctor Moyano, y a todo el comité científico junto con Ana, la secretaria nuestra, y la traducción simultánea. También quisiera también invitarles al próximo webinar que soportamos nosotros, que va a ser con el norte de Argentina, que es una sociedad de un grupo de amigos de Archilaco, los soportamos nosotros, que va a ser a mediados de mes, y sobre todo a final de mes tenemos un webinar muy interesante sobre escoliosis del adolescente, con la participación del doctor Lenke desde Nueva York. Así que os esperamos pronto para el webinar, que va a ser a mediados de mes, o el sábado a mediados de mes, 17 de octubre, y el sábado 31 de octubre con el doctor Lenke, para hablar y charlar sobre la escoliosis del adolescente. Muchas gracias, que tengáis buena tarde desde aquí, desde Las Palmas, y hasta el próximo webinar. Muchas gracias. Enhorabuena.
Gracias a todos.
Gracias.
Thank you all.
Thank you very much, Dr. Fessler.
Thank you very much, Dr. Fessler. Gentes, gracias, hasta luego.
Gracias.